Okay, let's then go through basics of water homeostasis. And these principles will arise in both our conversation of hyper and hyponatremia. So let's dive in. Total body water is something that we estimate for a number of our um, clinical decisions, okay, including things like KT over V. And of course, by now you recall that in general, we think of total body water as being somewhere between 50 to 60% of total body weight. And that differs depending on attributes of the patient. We don't need to belabor that. Let's compare and contrast osmolality versus tonicity. This is an important distinction. We can't measure tonicity. All that you measure is osmolality. You have to be able to correct for tonicity. What you're really interested in understanding water homeostasis is tonicity. Even though you can't directly measure that, we measure osmolality. Osmolality refers to the number of particles per mass of water, not liters. That's actually expressed in milliosmoles per kilogram. But we often simplify and say this is milliosmoles per liter, okay? Number of particles per mass of water. This differs from specific gravity, even though I do use specific gravity to make some clinical decisions. I might say that somewhere here. I'm pretty sure I do somewhere here, but I'll anticipate that. If all that you have is a urine-specific gravity, you're waiting for the urine osmolality to make decisions about a dysnatremia. There is a rule of thumb. You can use the specific gravity roughly estimates the osmolality. When you subtract 1 from the specific gravity and multiply that number times about 30,000, okay, that will give you an estimate of osmolality. That is flawed. You'll have to remember what is specific gravity from your grade school years. I think that's grade school knowledge, right? Specific gravity is the weight of a volume of liquid compared to an equal volume of water. So it's not a measure of particles like osmolality. It's a measure of weight. Presumably, if you have lots of particles in that water, it weighs more. But it turns out if you have heavy particles, that can have a high specific gravity, but a relatively low osmolality. The classic instance in which that happens is post-contrast CT. Okay, so be aware when you're trying to use a specific gravity to quickly make decisions. If you've recently had a contrast CT, that specific gravity can be very different from your osmolality. Okay, moving on. How do we discriminate between osmolality and tonicity? Again, the osmolality of the serum can be calculated based on this formula. Okay, plasma sodium, glucose, and urea are the main determinants of this osmolality in most individuals, okay? This is not a determinant of tonicity, though, right? Urea, we think of as not exerting tonicity. What is the difference between the two? Okay, so if I have water compartments, including ICF and ECF, okay, sodium is more than tenfold the concentration of the ICF sodium. Okay, so the ECF sodium is vastly higher than the ICF sodium, and that's because you have sodium potassium ATPase, and so sodium as an effective osmol, right? It can increase the flux of water from the ICF to the ECF. When you give hypertonic saline, you can reduce cerebral swelling by this phenomenon. Water moves from the ICF to the ECF. This exerts tonicity because of that. Glucose exerts tonicity, okay? Now, urea, on the other hand, does not. because when you have a plasma BUN of 200, that will show up as a very high osmolality. It contributes to the number of particles per weight or per unit volume. It contributes to osmolality, but it doesn't contribute to tonicity. It does not cause water translocation from the ICF to the ECF. And so it stands to reason you have to treat that differently. Okay? So even though the calculated osmolality is affected by the urea concentration, okay, it does not, urea does not affect tonicity. Okay, let's bring that to, again, clinical relevance. If you're using as one quick, frame of approach to a patient with dysnatremia, one of the first things you might do in a hyponatremic patient is check the osmolality of the patient to see whether this is a pseudo hyponatremia, for instance. Okay. If you are measuring osmolality in this individual and they have a high BUN, okay, you might falsely conclude that this hyponatremic patient is a pseudo hyponatremia because the osmolality is not low. Okay. You have to be able to recognize that the BUN does not, it affects osmolality, but it doesn't affect tonicity. A patient with hyponatremia and a high BUN is most likely a truly hyponatremic patient. If you use this as a first approach, the osmolality, and you say, okay, this patient has a normal osmolality with a serum sodium of 120, you might go down the wrong rabbit hole. You'll say, okay, this is pseudo hyponatremia. Everybody get that? You need to be able to recognize that. Okay, there's a difference between tonicity and osmolality. Okay, one way, again, that we can correct for this tonicity. We'll talk about correcting for this tonicity in a moment, okay? Tonicity refers to osmotically active particles. Urea is an ineffective osmol unless you're changing urea concentrations quickly. So urea can transiently be an effective osmol and may cause things like dialysis disequilibrium, can cause cerebral edema when you're dropping urea concentrations quickly before that equilibration takes place. Okay, so it can transiently affect tonicity, but not in the the long phase. Okay. Now, serum tonicity is the regulated phenomenon. The main effectors of water homeostasis are going to be thirst mechanisms and ADH. We do not regulate osmolality per se. When your BUN is 200, it doesn't make you more thirsty. When your BUN is 200, it doesn't make your vasopressin go up, okay? When your glucose is 1,000, it does make you thirsty. When your glucose is 1,000, it does make your ADH go up, okay? So you have osmoreceptors in the hypothalamus that are sensitive to cell size, okay? When they shrink in hypertonic milieu, then they will cause release of ADH or stimulate your thirst center. Okay, so again, normal serum urea. If I have a normal serum urea, my normal measured osmolality is 280 to 290, somewhere around that range. But again, if my serum urea is not normal, you may have a very different measured serum osmolality. Okay, there is a variation between individuals and certain disease states. And you certainly modify that set point through other stimuli. One of the most common is low effective circulating volume. Okay, so I can, let's put that in writing here. Okay, so if I have an individual who regulates their osmolality around 280, and therefore has a serum sodium of around 135, if I make that individual, if they develop heart failure, right? CHF. The CHF, that low effective circulating volume, may create a new set point of around 275, such that they defend a lower serum sodium, right? When their sodium gets to 125, they can dilute their urine, just like you would if you got lower than your set point. And when their sodium goes to 135, right, they can concentrate. Okay, so one thing that can change your set point might be pump dysfunction. Sometimes we have no clear low effective circulating volume, just being older and having, low solute intake, perhaps also individuals who are bedbound, they can have this lower set point. And we'll talk about reset osmostat as one cause of hyponatremia. Some people, there's some debate about whether that is an SIDH or it deserves its separate category of dysnatremia. Okay. I think I'll just end after I finish off this section. We'll talk about the mechanisms of control of water balance in more detail next week. Let's finish off this section right here. Okay. High effective circulating volume may similarly change your set point. And so let's do that on the flip side. Some people have described primary hyperaldo as being a situation in which my set point is set a bit higher. And so I have, let's make that 290. I have patients who have sodiums that are kind of on the high side. In primary hyperaldo, that is one explanation that's offered for why primary hyperaldo can sometimes have a little bit of hypernatremia associated with it. Okay, you shouldn't expect that. You shouldn't go and fall into the typical internal medicine resident trap, when you say, if you have a hypernatremic patient, they think, well, that must be a situation in which I have a sodium excess. You as a nephrology fellow say, no, hypernatremic patients have a water deficit. It's a water problem. It's not a sodium problem. Okay. Here's maybe a slight exception to that rule. When you have a primary hyperaldo, we think of there being a reset set point to a higher level. It's still, in essence, a water balance problem, but you can sort of make an argument maybe at its root cause is perhaps a sodium retentive problem. Okay. Again, when you have severe azotemia, you can correct and for this azotemia and try and sort of intuit what the tonicity disorder is by essentially taking your urea, subtracting a quote unquote normalish urea. That's where this number comes from, just plucked from the air. If you assume that a normal urea is somewhere around 20, then let's correct for whatever excess urea you have, and sort of give ourselves a tonicity from that. Let's correct for this this azotemia by subtracting 20 and dividing by 2.8, and giving an effective tonicity. You can do the same for when you have circulating alcohols, including ethanol, that can create also a measured tonicity, which is not reflected by the measured osmolality. Okay, and so there's a correction factor. I'm sure I have it somewhere in your field guide. I believe it's in our topic on acid-base homeostasis. So we'll get to that correction factor if I have a circulating alcohol, okay, to correct for that disorder or that osmolar gap, okay, that can arise from ethanol, isopropyl alcohol, or ethylene glycol. Questions before we end our conversation? Intro to water homeostasis.